So FLAURA was a long-awaited trial. It basically compares osimertinib to standard of care for patients with EGFR mutations having non-small cell lung cancer. So this trial was important because we didn't know if it was really important to use osimertinib in the first line, especially that we have very good agents that we can use for these patients in the first line setting. And basically we reserve osimertinib for the second line indication where we can get an extra benefit for these patients in the second line. So the basic principle of FLAURA was to try to see if we can get a very extended duration benefit with osimertinib compared to the strategy of using, for example, gefitinib followed by osimertinib for patients that have this indication in the second line. And basically this trial showed that there was much more activity than gefitinib, which was something that we kind of expected, but the benefit was sufficient enough that it seems to be superior to the actual sequence of events that I alluded to earlier. So osimertinib is probably better than using a very good agent in the first line like gefitinib followed by osimertinib. And you see that in the overall survival data that has been presented at ESMO this year. And the other great thing about FLAURA is the extra benefit in the brain. The question related to progression-free survival as being a main objective in this study is certainly something that is not, as a whole, the best marker of benefit, because you can get very good responses and very good sustained control of the disease if you use one drug followed by the other. So PFS on itself is great, but is not the only marker that you want to see. If the drug is good enough in the first line and you want to use maybe this drug in the first line setting, you would expect better survival overall. And another thing that's important compared to gefitinib and all the other first generation TKIs is the penetration in the brain. So osimertinib has much greater brain concentrations than gefitinib has, for instance. So what you like to see in this trial is if osimertinib will decrease the appearance of brain metastases and maybe delay the appearance of new brain lesions in patients that have or have not brain metastases. And that was a finding of the FLAURA trial, which was, for me, the most interesting piece of that trial, showing that you can protect patients from brain metastases. And in patients that do have brain metastases, you can actually control them better. So in FLAURA, for instance, osimertinib was compared to either erlotinib or gefitinib because both treatments were allowed. And the basic side effect profiles we knew already because we have clinical experience with osimertinib, we have clinical experience with either erlotinib or gefitinib. So the results of this trial was not a very big surprise. We do have side effects with osimertinib, so it's not an adverse event-free agent, but it's usually as well tolerated as gefitinib that I consider a very user-friendly agent to use for my patients with lung cancer. And in some instances, it's even better tolerated. So I don't think that toxicity concerns will be very important when we make decisions about which agent we want to use in the first-line setting. So as I've said before, the principal reason why I would select osimertinib in the first-line setting is for protection of brain metastases. Patients with EGFR mutations have a life expectancy now that goes beyond 3 to 4 years. These patients will get, for the most of them, brain metastases, and issues related to treatment of these brain metastases become very important down the road. So these patients get whole brain radiation, stereotactic radiation to their brain metastases, and they end up having they end up having symptoms related to the prior treatments that they've gotten. So if you have an agent that protects the brain and allows a patient to have an overall health status that is good because their systemic disease is treated, but at the same time their brain disease is treated, then I think you have a much better agent to propose to your patient. So I think that's probably the most important reason why I think this agent is superior to any other we have right now. Well, for the time being, osimertinib is not approved first line, so I think the study gives very good data to support potential licensing of this drug for first-line use. And I think it has sufficient interest to convince third-party payers or government to consider funding this agent for first line. So in a medical sense, I think it has much potential interest in terms of getting reimbursement. We'll have to wait and see what our payers say, but I would certainly be very optimistic that patients will have access to this agent very soon. On a very personal level, this study for me was one of the most interesting papers that were presented at ESMO in Madrid. So I was very happy to see the results of this trial. I think it sets a standard, and it goes with some evolution in the way drugs are developed now. I think brain activity has long been a major hurdle in the way we treat our patients with different types of cancer. For many years, chemotherapy has been used, and we knew that chemotherapy didn't go well into the brain, and patients ended up having brain issues. The first generation TKI has the same problems. The disease is very well controlled. You don't see any lung disease anymore, no more brain, no more liver metastases, no more lymph nodes. But all of a sudden, all these brain metastases show up, and you end up losing the battle just because your agent doesn't cross the blood-brain barrier. And this agent seems to do this quite well. And we had some other experiences where Alex was presented this year at ASCO, so just a few months earlier, showing that in other type of lung cancer, ALK-related lung cancer, if you have a better agent that penetrates the brain, you get better brain activity and better results overall. So I think it's exciting times just because the way we're going to treat our patient is going to be altered by the way these agents are conceived.